Okay, so now we'll start our ophthalmology section. Again, some of this will cover some antibiotic stuff, but since you're already in the mechanisms of action, we have to get to that pretty quick. So essentially, hopefully no one has a phobia of needles going anywhere towards the eye. There's lots of different places you can apply medications to the eye. Certainly topical, you'll end up seeing being kind of the more frequent one being done because it's pretty easy, right? You can just apply it directly to the eye, no problem. But certainly there are other places. So you can have subconjunctival applied medications. You can have things that are applied retrobulbar route or the peribulbar route. But again, most of the drugs we'll talk about today are going to focus more on the topical route. Looking at just the fact that we use topical is because, one, it's very convenient, very economical, and it's relatively safe. It's hard to really screw up applying drops directly to the eye, unless you can actually poke yourself in the eye, I guess. The big thing you see with limitations is that compliance can be an issue, especially if you have, say, a child who does not want drops being applied. They can be very difficult to deal with. If you have adults that don't want to do it either, we'll end up seeing that systemic absorption of medications is a very real thing that can happen with topically applied ophthalmic medications. So that's one thing to be concerned about, and that's due to nasolacrimal drainage, as we'll see. You'll see that these other agents or other routes of administration are going to be much more invasive and typically will be done by an ophthalmologist or something in more kind of specialized cases. This is why we'll focus on the topical. You'll see that most drugs are going to be given as solutions. The suspensions for the drugs may be given for things that have limited solubility. So we kind of talked about the difference between solutions and suspensions. Suspensions, always make sure you're shaking up really good because otherwise the drug may settle out at the bottom. And so really one of the thing you'll see with some of these dosage forms is that they're designed to spend more time in contact with the eye. So things that are thicker, things that have more viscosity, that stick around longer in the eye are going to have more contact time and thus can have a longer duration of action while they're in contact with the eye. So if you see gels, ointments, a lot of that is due to increased contact time with the eye. Sometimes you even see solid inserts that might be used. And there's actually, here we have an implant that can be placed. This is again cyclovir implant that's put in for CMV retinitis or cytomegalovirus retinitis, and that actually has these drug-eluting cells that will allow the drug to kind of leach out over a long period of time. So that way you're not applying a drug topically that may not stick around for very long, but it goes right to the site of action.
Where do they insert? Where do they insert?
I'm not sure actually where they're going in at, but basically they're going right to the globe. So, yeah. Someone asked when they have to remove that. Actually, I don't know that either. So that's probably a very specialized kind of ophthalmic thing you'll probably learn if you go work in an ophthalmologist's office. So looking at the pharmacokinetics of ocularly applied medication. So again, rate and extent of absorption is going to depend on a number of different things. So one, the time in the cul-de-sac. So again, the time the drug's actually there in contact with the eye, and also the precorneal tear film. Looking at nasolacrimal drainage, so the faster stuff drains out, the less contact time with the eye, the less absorption. We'll look at the drug binding to tear and tissue proteins. So if drugs are binding to the tear and tissue proteins, they're going to stick around for longer. So that'd be a good thing. And then also looking at diffusion across the cornea and the conjunctiva. So we mentioned Fick's law probably last class or the class before, right? We'll talk about that in a second. But basically things that are more lipophilic, they're able to cross the actual cornea, the better absorbed they're going to be. And again, this can be affected by changing the formulation of the drug, or in even some cases you may see like blocking of the tear ducts. So you can either use like silicone plugs or cautery to actually close off the nasolacrimal drainage, usually for patients with like really bad chronic dry eye or something like that. So looking at the absorption, nasolacrimal drainage is going to account for the majority of systemic absorption that occurs. The other big thing here is, you guys remember what first pass metabolism is, right? What is it? Yeah, so things that are applied orally, they go through the liver and you kind of pay the liver tax, and basically it decreases your bioavailability. Going through the nasolacrimal drainage, you're going to have better absorption because you're bypassing the first pass metabolism, right? And so you can actually see patients who are developing systemic side effects from ocularly applied medications. So when we talk about beta blockers, that's going to be one of the big ones. I can have a patient have bradycardia if you're having a beta blocker applied to the eye, right? It's all because of that nasolacrimal drainage there. And again, for a drug to usually be effective, you need to have this transcorneal absorption. So this lag time is going to be considered the amount of time it takes from a drug applied topically to actually have that penetration through the cornea to have its effect. So especially if it's trying to work with, intraocularly as opposed to just, say, in the conjunctiva. We'll see that the rate is going to be dependent on things like the concentration gradient, similar to what we talked about dermal absorption, and it's governed by Fick's law. So So as we see here, the bigger the surface area, the more absorption you're going to have, the bigger the concentration gradient, more absorption, and then the thickness is also going to be a factor here as well. So usually the eye is pretty thin, so you generally get pretty good absorption depending on the drug. So as far as distribution goes, it's going to happen, if it gets absorbed systemically, it's going to happen just like it would with any other drug applied systemically. But you may actually see some drugs actually accumulating within the eye. We'll talk about one antiviral that does this, but this is an example of a bullseye lesion that actually can occur after systemic administration of chloroquine. Chloroquine is an old school antimalarial medication, and so you can actually end up seeing these accumulate in the eye over a period of time when it's being administered. As far as metabolism and excretion goes, things typically, if they get absorbed systemically, will be metabolized normally either through the liver, secreted through the kidneys, whatever happens to be. But actually some drugs are prodrugs. You guys know what prodrugs are? So prodrugs are, it's a good concept to know now. Prodrugs are drugs that themselves have no therapeutic activity. But when they get metabolized, either by the liver or wherever it happens to be, now they are active, right? So take, for instance, everyone's heard of codeine, right? Codeine's an opioid analgesic. Codeine has really poor analgesic activity itself, but when it gets metabolized by the liver, it gets turned into morphine. Morphine does have really good analgesic activity. So that's a good example of kind of a prodrug, right? So other examples of this would be like dipivefrin gets metabolized into epinephrine. Epinephrine, is a catecholamine, can have some vasoconstrictive effects, and then some of the ones we'll see used for glaucoma, like latanoprost, actually gets converted over into prostaglandin, and that'll have some positive effects for our glaucoma patients. That makes sense for prodrugs? We'll see lots of examples of prodrugs as we move forward. Okay, so looking at ocular antimicrobials, we've covered a lot of these drugs already, so I won't spend too much time talking about them. But essentially, when we're treating ocular infections, the really big thing to look at is how extensive the disease is. Is it preseptal? Is it really just kind of affecting the conjunctiva or wherever, kind of more surface level, or is it more, say, postseptal, where you have an orbital cellulitis, where it's more kind of diffuse? And that'll kind of lead you to decide if you need to use topical therapy versus more systemic therapy. So in a lot of cases, it depends on patient specific. So, do they have some kind of preceding trauma, something that would make it more likely to have involved disease? Look at the age of the patient, because obviously immunocompromisation comes with the extremes of age. Do they have cancer, HIV? This can also make them immunocompromised, and just how extensive it is. So it's a very kind of surface level, looks like just the conjunctiva is being affected. You can utilize topical antibiotics versus if it's an AIDS patient who has had some kind of penetrating wound and really diffuse disease, they may need more systemic therapy. That'd be a pretty bad patient to see, but just to give an example. So looking at the microbiological spectrum, you'll see it change over time, especially as different vaccines come about. H-flu certainly has gone down in rate since we've had introduction of the vaccine. And just keep in mind that using topical therapy may not be enough. You may need to use more parenteral therapy or oral therapy. Everyone know what I mean when I say parenteral? Basically, that means intravenous therapy, right? So something I'm applying to the veins was often intravenous, but it could be other routes. It could be intramuscular, things like that, subcutaneous, but basically you're applying it directly into the bloodstream in some shape or form. So for small, mild, or peripheral infections, typically what you're going to see uses these topically administered products. The benefit of using topically administered antibiotics is, one, you have very limited systemic bioavailability, which means you don't have to worry about systemic side effects, like we saw with a lot of these drugs. You're going to have high local concentrations, which means that even though the drug, the bugs might be normally resistant to, say, systemic levels that I could get by giving an oral dose, you can get really high concentrations at the eye and really overcome that resistance. So it's very difficult, or usually you don't see a lot of resistance to topically applied antibiotics like that. And then the negative effect, though, is that you're going to need frequent dosing. So if you ever have been prescribed eye drops, you may need to apply 4-6 times a day in order to really get kind of prolonged, good effect out of it. Typically, the antibiotics we're going to use are going to be broad spectrum because, again, we're not as worried about resistance because we're using such high doses or high concentrations. And for the most part, you're not going to get cultures for these type of infections unless you're really worried about it being a more immunocompromised patient, or maybe they're having a fungal infection, maybe it's viral. For the most part, you can just prescribe your patient one of these antibiotics. They're usually good to go. We'll talk about some exceptions to that, though. So again, we know conjunctivitis, you'll end up seeing this mild hyperemia, purulent discharge. Commonly, it's not bacterial at all. Most of the time, it's just going to be viral, right? Other things that can cause it include environmental irritants, contact lenses, allergies. Less commonly, you may see systemic diseases or tumors that can cause conjunctivitis. But mostly, when you see infectious pathogens, you're looking at things like Neisseria, things like Haemophilus, Streptococcus, Staph aureus. So it's kind of a hodgepodge of different things because, again, your hands are kind of touching everything, and then you touch your eyes. Who knows what's going to get in there, So lots of different bugs can cause this, which is why we use a lot of broad spectrum antibiotics for these cases. And again, big thing we're focusing on is have eradication of the infection and prevent long-term complications from occurring. So these are the different drugs that you can potentially see being used. Obviously, you've seen most of these before, right? Right. Don't memorize the formulations. I'm not going to focus on that so much. I may talk about, say in a test question, which formulation might be best for a certain type of patient, which we'll talk about. But don't memorize that, azithromycin comes as a 1% solution. You don't need to know that. And also don't memorize all the indications for use. We'll talk more about specifics, but just know that we'll look at conjunctivitis as kind of a broad topic here, but they can be used for lots of different types of inflammation in the eye. So the first one is our macrolides. Remember, they're affecting protein replication at the ribosome. Again, biggest adverse effects you're going to see from these agents, even though they're pretty well tolerated, it's going to be some eye irritation, maybe some hypersensitivity. But again, you'll see that with almost all of these drugs, so I'm not going to really belabor that point for every single one of them. Just know some people are going to be more prone to irritation from these drugs than others. The two big ones you're going to see used are going to be erythromycin ointment, which is the most common, and then also azithromycin, which comes as a solution. Erythromycin, you'll see that when you have these gels, that there are going to be, or ointments are going to be typically dosed in inches. So you may see like apply half an inch to the eye. That's typically what you see with like ointments and gels and things like that. Notice the frequent dosing you're going to need to do, say 2 to 6 times per day, depending on the severity of infection, right? So you may need to apply this pretty frequently, which may be difficult for your patients to keep up with. Azithromycin is available as well. This one, because it has a little bit longer half-life, this one you can usually get away with using just twice daily, which is nice. Now, because I said most of these are going to be viral in origin, erythromycin is pretty soothing by itself. Just having a nice ointment there can kind of help soothe the inflammation of the eye. So even if you don't really think it's bacterial in origin, even just giving them erythromycin ointment is probably not going to harm anything because you're not really worried about resistance. It's going to just be beneficial for them in the long run. So even if it's not confirmed bacterial conjunctivitis, erythromycin might be okay for them, right? Azithromycin, on the other hand, is considerably more expensive. Erythromycin ointment is super cheap. But azithromycin might be better for patients who you have a confirmed bacterial conjunctivitis. You're worried about compliance, and you can let them give it less frequently. And then like I said, because of these facts, you won't really see it used as often clinically. We can also see a combination of trimethoprim, which remember inhibits what in the bacteria?
Folic acid.
Yeah, it inhibits folic acid synthesis. And then also polymyxin B, which remember is a different type of drug that actually works by piercing through the bacterial cell wall. So you see a different combination of a couple of different mechanisms here. Essentially, these can be used for lots of different types of conjunctivitis as well, and of bacterial origin. Again, no drug interactions because you're not really worried about that with these topically applied drugs, and no special adverse effects here.
Really quick, so previous class you said that the polymyxin wasn't used, it's not regular for like 50 years.
Yeah.
Is that the systemic?
That's systemically administered parenteral polymyxin. When you apply it topically, you see it used all the time. Dermally, you see it used all the time. Think about your triple antibiotic ointment contains polymyxin in it. Yeah. Because it doesn't get systemically absorbed, so you don't worry about the neurotoxicity and CNS or nephrotoxicity and all that good stuff. You'll also have sulfacetamide being used by itself. So remember, this also inhibits folic acid synthesis, but just at a different step. Very similar irritations. Be aware if your patient has a sulfonamide allergy, probably want to avoid this drug. Okay, so that's really important to review in your patient's history. Another one we have is Bacitracin ointment. This one probably don't see quite as often, but it does have some good ability. Certainly you see it used dermally all the time for cuts and scrapes and things like that. This one is going to also inhibit cell wall synthesis. I know we didn't talk about it in an antibiotic lecture, but it will help to break up that bacterial cell wall. Again, this one comes as an ointment, so it'll be dosed in inches usually, so like half an inch, say 1 to 3 times a day. The nice thing with these ointments is that even if you have, say, like a fussy kid who's trying to fight you, even if you just get this on the eyelashes, like you can still make contact with the eye and still get some benefit out of that. If you're just applying a solution, it can wash away very easily. You might not have a whole lot of contact time, but just having the ointment there, kind of just smearing it on may be enough to kind of make local contact. Does that make sense? Mm-hmm. Does anyone know what to do if you glue your eye shut with, say, super glue? Also use erythromycin ointment. That can actually help to break down those bonds there in the super glue. So,
do kids do this?
Kid, absolutely. You haven't seen, yeah. So you never glue your eyes shut or anything like that? No. Kids will do it. Typically, it's more like the eyelashes getting glued kind of down to the bottom of the eyelid. But yeah, so just a little bit of erythromycin, just kind of slather it on. Eventually, it'll just kind of break up on its own. You can also use fluoroquinolones. Now, these you probably want to reserve for special cases. So you can see things like ciprofloxacin, ofloxacin, moxifloxacin. Moxi is probably the biggest one I see used frequently. We said these inhibit DNA gyrase, topoisomerase. Big thing here to note is that these are going to be better for patients in whom you're concerned about Pseudomonas. Right, so if you're concerned they have a pseudomonal infection in the eye, this would be kind of your more go-to drugs. As far as adverse effects, one thing to note here is that Cipro can actually precipitate out and leave kind of this this white kind of crusty stuff in the eye, which may be something you want to let your patient know about beforehand, so they don't think they're just getting worse. Also, they can have an unpleasant taste after installation. A lot of that's due to that nasolacrimal drainage kind of going to the back of the throat. We talked about the mechanism here. So again, if you're especially corneal ulcers, if you ever see those are good for use of fluoroquinolones. And then if you have a patient who has a really bad conjunctivitis and is related to say like a contact lens, oftentimes you'll see Pseudomonas being more frequently in those patients with contact lenses. Again, these are more expensive agents, so we'd like to hold off on these unless we have a good reason to use it. And also there's emerging resistance, so you're more likely to see resistance against these guys than you are to a lot of these other agents. So again, contact lens is probably the big case. So if you had a patient who, had a history of wearing contact lenses and has failed other therapy with, say, Bacitracin or erythromycin, and now they need something else, like fluoroquinolone probably is going to be your next go-to drug, right? You'll see some aminoglycosides being used ophthalmically. Gentamicin probably being the more frequent one. This is the thing you get rubbed on as a neonate as soon as you're born, because again, it helps to prevent infection from the stuff you get coming through the birth canal from mom. We know these are going to be affecting our 30 and 50S ribosomes here to prevent bacterial to prevent protein synthesis here. Again, you will see the potential for corneal ulcers to actually occur from these medications, which is why they're not used very frequently. So that would be one thing to note with these medications, why they don't get used very often. Then you can even see after several days of use kind of this reactive keratoconjunctivitis. So not used frequently, but they can be useful, especially if you're worried about Pseudomonas as well. So if you didn't have a fluoroquinolone, you can get away with using something like gentamicin instead. Yes?
Would it be used on every birth, or just if they think that the mom has that?
I don't know if they're used on C-sections or not, but I certainly know if it's a natural vaginal birth, I see them use the gentamicin there. Just get like a one-time dose, and then that's it. Yeah. Okay. So looking at antiviral therapy, you will typically see antivirals being used for viral keratitis, herpes zoster ophthalmicus, or something like a cytomegalovirus retinitis. If you just have like a regular viral conjunctivitis, we don't really have any drugs for that, right? So if you have an immunocompetent patient, someone who does not have any immune suppression, we don't have any antivirals for them. But if you had someone like an AIDS patient who were worried about CMV retinitis or something like that, these would be some of the medications we can use to treat them. So notice that most of the drugs that we could use to treat these patients would be oral or intravenous in nature. So things like acyclovir, valacyclovir. I'm not going to talk about those because I really just want to focus on the ophthalmic medications. So the two that we'll see here are going to be trifluridine, and then also the ganciclovir. That's that insert that we showed several slides ago. So those would be the two to focus on for this section. So trifluridine, it's going to be working, and as most antivirals do, they're going to be working by inhibiting viral replication by basically inhibiting DNA synthesis. And what they do is they actually will kind of go in as false base pair. So when viral DNA is replicating, these things will get incorporated into the DNA, and they prevent further elongation, and that's going to trigger cell death or viral death at that point. So this one actually goes in and inhibits thymidylate synthase, and so it prevents further elongation after it gets kind of mistaken as a thymidine base. You'll see this being utilized specifically for keratoconjunctivitis due to herpes simplex virus. And then as far as adverse effects go, the one unique thing here you see is this kind of punctate keratopathy. So that would be a unique thing to this drug you don't really see with anything else. And then again, cyclovir, this one is going to be working more by blocking guanosine from being added to the DNA. So again, it gets incorporated into the DNA itself, and it doesn't really have that sugar backbone to continue elongation of the DNA. So it gets inhibited and the virus dies off. This one can be seen used for herpetic keratitis and also for cytomegalovirus retinitis. So again, these are going to be for more immunocompromised patients, not for your run-of-the-mill, showing up with an inflamed eye kind of patient. So again, just to picture how this one would be working, very similar to things like acyclovir and other antivirals. It gets phosphorylated when it actually gets into the virus, and then when it gets to that triphosphate form, it gets incorporated into the DNA, and there's no sugar molecule on the back of it to actually elongate any further. Okay, looking at ocular antifungals, there's only one antifungal ophthalmic product that's available, and this is going to be natamycin. All the other things that might be available are kind of either made at compounding pharmacies or things that you're not going to see all that frequently, but natamycin might be one. And again, as you have more immunocompromised patients, you're more likely to run into these fungal infections, and so natamycin might be used for them, especially if they have any kind of like trauma. Contact lens wear can increase your risk for developing fungal infections, and just immunosuppression in general. That includes patients who say who've had topical steroids applied to the eye for a chronic period of time. They might be more at risk for fungal infections as well, because you can kind of have like a local immunosuppression due to that. So notice again, most of these are going to be not commercially available, so the only one on this list I focus on is the natamycin. This one's working by actually increasing cell membrane permeability in the fungi. So again, more specific fungal cells, and helps to open up the cell wall to allow the contents to leak out. And you'll see it used for lots of different types of fungus, Aspergillus, Candida, things like that. Nothing real special as far as adverse effects go. Okay, so again, whenever you have a patient who's presenting with an eye complaint, you always want to make sure you're doing visual acuities before you apply any drugs, because you want to make sure you can check for any trends that are going on, right? Because you want to look at kind of pre and post treatment to make sure things are not happening. Make sure you're documenting allergies to any medications that occur, and make sure you're kind of doing your follow-ups and making sure that their visual acuity is not going down over time. If things are getting worse, you're not sure what you're doing, because the eyes are so important, you want to make sure you get your consult with ophthalmology or kind of forward that along to make sure you don't miss anything. How do we apply ophthalmic medications? One, most important thing, wash your hands, because you don't want to get yourself another infection. And then always avoid having the patient touch the dropper to anything, so especially any kind of skin contact. You want to keep this thing as sterile as possible, so avoid contact with any kind of skin or mucous membranes. And so the first thing they'll do is kind of pull down the lower eyelid to help kind of form pockets, so they can kind of just instill the medication directly into the cul-de-sac there. They're going to hold basically the dropper with the other hand as close as possible without touching it, and they'll basically squeeze how many ever drops they need onto. Or if it's an ointment, they'll kind of squeeze, they'll kind of guesstimate half an inch. The dosing isn't really so important there for those kind of indications. The next thing you do is you want to go ahead and have them close their eyes and tilt their head forward, and then actually hold their fingers over the lacrimal duct. And what do you think that does for them? Yeah, so it prevents nasolacrimal drainage to occur for some period of time, so that way you can have less systemic absorption potentially, and then also it allows a further contact time with the eye itself. So it kind of keeps the drug around for longer to have its effect. It allows it to be absorbed into the eye itself. So do that for 2 or 3 minutes or so, and then after you're done, wipe away the excess and go ahead and wash your hands again. So again, ointments are typically better for kids, especially because they're poor compliance. They're difficult to get things into their eyes. Even if the eye or the drug is on the eyelashes, it can still make some contact, so you still have some efficacy there. With ointments, you see more vision blurring, so about 20 minutes or so. So make sure their eyes are clear before they decide to drive or operate heavy machinery. And like I said, no big difference with the gels and ointments as far as application goes, but because it has better staying power, because it's more viscous, there's no need to really cover the lacrimal duct. With contact lenses, it's important to make sure that they are discontinuing use of contact lenses while they're having the infection, and make sure that they don't resume use until the eye is no longer inflamed for at least 24 hours, right? So not inflamed, no discharge for 24 hours, and they can start using them again. If they are, if they have the infection with the contact lenses, throw them out. Don't reuse them. Some people are pretty cheap and they might try to reuse them, but that's gross. Throw them out. And then I also would recommend getting rid of your eye makeup. So hopefully they weren't using anything too expensive, maybe from Ulta or something. But they should be getting rid of it. But who knows? People don't always listen to what you say. Okay, moving on, we'll talk about our next set of drugs. So we're going to talk about more of an allergic conjunctivitis. So again, the main things that are going to be occurring here is we're going to be using antihistamines, right? So we know that these are the principal cells in allergic reactions are going to be things like the mast cells, the basophils, and then when you're producing these IgE antibodies, you're going to generate and basically be generating all kinds of inflammatory cytokines, things like tyrosine kinases and etc. And then these mast cells are going to be releasing things like platelet activating factor, histamine, leukotrienes, serotonin, all kinds of stuff. And basically what you end up seeing is this kind of traditional response to these inflammatory mediators: vasodilation, swelling, redness, itching. I'm sure everyone's had a similar reaction as this person's having right now, right? Sure. Unless they're doing something else, which it gives you red eye. I don't know. No judgment here. But anywho, so as you can see, when you have release of things like histamine, essentially what you're having when you're having the redness is that it basically makes the blood vessels more leaky, kind of increases those capillary spaces so the fluid can leak out. So you see the hyperemia, that's where you see the edema and things like that occurring here. So some of the drugs that we can use are going to be our H1 receptor antagonists. So these are specifically going to be referring to ophthalmically applied H1 receptor antagonists. There's a couple of different histamine receptors. We'll talk more about them later on in the class, but H1 receptors are the big ones we worry about for allergic responses. H2 receptors are going to be more big for things like gastrointestinal issues, especially if you see things like your Zantac and whatnot being used as H2 blockers. But here are H1 blockers. And so what they're going to be doing is competing with histamine and actually causing an inverse agonism effect, but don't get caught up in that. It's something from pharmacodynamics. But anywho, what they're going to do basically is decrease capillary dilation, decrease the itch, and decrease the swelling by antagonizing that receptor. So some of the available agents, we'll talk about this MCS, which is mast cell stabilizing properties. We'll talk about those in a second with some other agents. But the antihistamines you see most often are going to be things like zelastine, imidastine, epinestine. Ketotifen or Zatador is probably the one to make a special note of here because it's over the counter. So it's probably more frequently the one you see being used. And then olopatadine or Patanol is another common one. So keep in mind that these are going to be used, say, 1 to 2 times daily. If the patient knows they're, in an allergen season, or if they know they're about to be exposed to something that's going to cause this allergic conjunctivitis, they can apply it beforehand. The antihistamines work much faster than the other agents we'll talk about. So, onset of action is within minutes because they immediately get to those histamine receptors and block the effects there. Make sure your patients are using it for at least 2 weeks before they can assess full efficacy. And then as far as adverse effects go, the biggest thing you might see is, say, increased ocular dryness, maybe some ocular irritation, but those are kind of the most common ones you're going to see. They don't really get systemically absorbed to a big extent, so you don't see a ton of drug interactions. And these are typically going to be preferred agents over our mast cell stabilizers, as we'll talk about in a minute. So mast cell stabilizers, what these are actually going to do is prevent those mast cells from destabilizing in the first place. That makes sense. If you prevent the histamine from being released and all the other inflammatory mediators, you prevent the inflammatory reaction from ever occurring, right? Well, what happens if the mast cells have already degranulated? How effective are they going to be? Not really effective, right? So these are better as control medications because they help prevent the inflammatory action from occurring in the first place. Whereas with their antihistamines, they can actually directly work against the histamine receptors themselves. So if you're having an acute reaction, so say like someone brought a cat and rubbed it in my face, and also my eyes are nice and red and hyperemic, mast cell stabilizers are not going to do it for me. I need to have an antihistamine in order to block those effects. If my test is bad, don't rub a cat in my face. That'd be bad. They also help to inhibit further leukocyte activity, and again, help to prevent the release from basophils, eosinophils, neutrophils, and all that good stuff. The ones you'll see used here are going to be your cromolyn, lidoxamide, and netocromel. Again, very similar to what you saw before, a couple weeks before you can see full efficacy. Again, these are not useful for acute symptoms. but they're better as controller medications to help prevent the reaction from occurring in the first place. They also have to be applied more frequently, so they're not as going to be, compliance is going to be more of an issue with your patients than something you can just do once or twice a day. But they may be useful for patients who cannot tolerate antihistamines for whatever reason, say they have an allergic reaction or something, and they know they have very predictable symptoms. So if they know, come fall time, or springtime, whenever the pollen's out, that they're going to have reactions, they can utilize these as controller medications beforehand. In some cases, you can utilize an antihistamine in combination with a vasoconstrictor. Vasoconstrictors are obviously going to help to constrict down on those blood vessels directly to help decrease a lot of the redness and the swelling. So some available agents, some of the over-the-counter ones that are just the vasoconstrictor themselves, are going to be things like Tetrahydrozoline, otherwise known as Optaclear. You have Nefazoline, and then you have a combination product here, phenyramine and Nefazoline put together, right? Now, the big thing with these guys is that as vasoconstrictors, if you constrict it for a long period of time, and these are mainly working by activating the alpha receptors on the blood vessels, right? So those are constrictive effects. Now, if I were to constantly activate those receptors, what does the receptor count do? Does it say upregulate or downregulate? Right, because it's constantly being hammered by these drugs, right? So it's going to start to downregulate, right? So if I were to take away the drug all of a sudden, what's going to happen? Well, they're not going to upregulate immediately. Now you have these blood vessels that have fewer alpha receptors, and now they can't be activated as well by your endogenous vasoconstrictors. They're just open wide open, or open right up, right? So you end up having this rebound vasodilatory effect, where you end up having this rebound hyperemia that can occur. So these are better for short-term use, say less than 2 weeks, because otherwise, if you were to do, say, I use this for a month, and all of a sudden I stop taking it, I'm going to have all kinds of rebound hyperemia and swelling that can occur.
Can you just explain that first line again?
Yes. So the vasoconstrictors work by basically working on the post-junctional nerves, right? So after the nerve junction, they work on those post-junctional alpha receptors. And when you activate alpha receptors on these blood vessels, they cause constriction.
How does that help the reaction?
Because if you're having, if your blood vessels are, the histamines and things like that, they cause vasodilatation to occur. Okay. So by causing that, you're going to decrease the capillary leak, and you also decrease a lot of the redness and things like that. Yep. So again, with a lot of these products, since some of these are available over the counter, the problem is you don't want, a lot of patients are going to be self-prescribing these medications. So you want to make sure that if they're having these reactions, if they're not seeing any improvements, they need to go get checked out, because they could be missing a bacterial case of conjunctivitis. They could be missing something big that can lead to permanent damage, right? So you want them to make sure they check in with you guys if they're not having any improvement. So again, just to kind of go into further detail about these drugs, we call those imidazoline derivatives, like your tetrahydrozoline, things like that. And so essentially what they're doing is that systemically, and this will be important when we talk about certain things, but basically, systemically, they work on alpha-2 receptors. And what alpha-2 receptors do is they work in the brain to actually decrease the amount of catecholamines being released. So epinephrine, norepinephrine, they decrease that systemically. But if I were just to apply it locally to the eye, they work on those alpha-1 receptors to cause the vasoconstriction. Where that becomes important is because these drugs are very potent, that if, say, a kid gets into them, say they ingest this stuff, say they get into some Visine or something like that and they ingest it, those effects in the CNS to decrease catecholamine release can lead to things like bradycardia, hypotension, CNS depression. So kids can get very, very sick if they actually accidentally ingest some of these products. So it's really important to keep them out of reach for kids.
Can I ask a really silly question?
There are no silly questions.
On Wayne Crashers, when he drinks when he drinks like the drops in the drink, is that what?
Supposed to give him diarrhea or something?
Yeah, he's vomiting.
Yeah, so it doesn't actually happen. And there's actually a story where either a wife was trying to do it with the husband or vice versa, try to give him like really bad diarrhea, and she actually the guy got really sick, and I think the wife got like arrested for it or vice versa.
So it won't make you vomit?
Not necessarily, unless it's probably not pleasant tasting, but no. Yep. Does not work based on the pharmacology of the drugs. But there have been kids who are basically like comatose from receiving because they're just not releasing a lot of catecholamines, because this is basically when you activate those alpha-2 receptors on the presynaptic junctions, it's telling the brain to stop sending out those catecholamines. So heart rate will drop, blood pressure will drop, and we'll talk about some antihypertensives that actually work through the same mechanism as well. But the important thing here is that when you're applying them locally, they're working on the alpha-1 receptors directly on the blood vessels to cause a vasoconstriction. Okay. Some other medications you can see used for inflammation in the eye include our non-steroidal anti-inflammatory drugs, otherwise our NSAIDs. I'm sure you guys know of some NSAIDs, right? What are some examples? Ibuprofen. Know any other ones? Yeah, leaves naproxen, right? Absolutely. So essentially what these are going to be doing is inhibiting the action of cyclooxygenase, which otherwise known as COX as it gets abbreviated. So essentially what they do is that they inhibit the conversion of arachidonic acid, which is usually liberated from, say, cell membranes. You can use some of the phospholipids in the cell membrane to form arachidonic acid. That then gets converted by cyclooxygenase into inflammatory mediators. There's a couple of different varieties. We'll talk more about these when we get to pain management and things like that. But essentially, when you're having inflammation occurring, the big cyclooxygenase you're worried about is this COX-2. This is the inducible cyclooxygenase. That is when you have an inflammatory reaction, or say you sprain your ankle or something like that, COX-2 gets upregulated. You produce a lot of these inflammatory mediators, your prostaglandins and things like that. And prostaglandins are very vasodilatory. This is where you see a lot of inflammation come from there as well. It's where you see the hyperemia, edema, and things like that. COX-1 is going to be more constitutive, which means it's around all the time, and this is why it's really important for gastroprotection and things like that. So when we talk about NSAIDs and their effects on the stomach, a lot of it has to do with that interference with COX-1. But just know that primarily what we're focused on is this COX-2 activity. So a couple of different NSAIDs that can be used here, so things like diclofenac, ketorolac, nepafenac, things like that. You don't typically see these being prescribed very frequently, and the places they're mainly used are going to be for like post-operative inflammation and allergic conjunctivitis. So this is more for like patients who have failed other therapies for allergic conjunctivitis, or if they're like in a post-operative setting and they need something to deal with that inflammation from manipulating the eye. So again, not routinely recommended. Usually going to be seen more with the ophthalmologist being utilized. Some of the problems, and because there are more side effects, is why they don't get used as frequently. But you can see things like intraocular pressure increases, which can be bad for glaucoma patients. You can also see some inflammation like keratitis coming from these as well.
What's the inflammation?
Just increased tear production. Yeah. You can also utilize glucocorticoids ophthalmically in order to help decrease inflammation directly at the eye. Again, these are going to be working kind of at an even higher level than your non-steroidal anti-inflammatory drugs are, because before you even liberate the arachidonic acid, your steroids have already been working at the nucleus to prevent some of that gene transcription from occurring. So they're working at an even higher level to decrease inflammation. They also take longer to work because of that. Where these are used is because we know that glucocorticoids work to decrease wound healing and things like that. You can actually use this to help decrease scar formation in, like, say, post-operative settings in the eye itself. So you may see these being used if, say, they failed every other therapy for an allergic conjunctivitis, if they're having anterior uveitis, if they've had inflammation after ocular surgery. You might be seeing these being used here. They can be applied topically, which you'll see probably more frequently, and then also intraocularly in some cases. Again, just to look at kind of a general idea what the corticoid actions are going to be, they're decreasing inflammation basically from soup to nuts, decreasing it all the way from the nucleus itself to decrease a lot of these inflammatory mediators from ever being formed. So the reason why we don't want to use these unless we don't really have any other medications is because of the side effects. So you can see things like cataract formation, you can see increases in intraocular pressure, probably more in people who already have a family history of this. Because it decreases immune function, you can see secondary infections, delays wound healing in some cases, maybe not the way that you want it to, not necessarily to decrease scar formation, but if you had a wound, may not heal quickly because of this, and can cause corneal ulcers itself. So you really want to have limited therapy for short duration at times. You really don't want to be using these all the time. Really need to be more reserved for refractory cases. Yes?
I thought it was good for post-op eye surgery.
Yeah, it is to help. So if you were concerned about scar formation, say in a particular part of the eye, that maybe could potentially be used there. But say you had like an injury, or having a lot of ocular inflammation, you need, say it was like a trauma or something like that. This might actually prevent wound healing in those cases. So it really depends on the case. If you ask an ophthalmologist, they probably have a more in-depth answer for you for that stuff. Lots of different ones that are available. So look at things like dexamethasone, prednisolone. The ones that have stars on here are considered to be soft steroids. And so these are actually better for patients who have increased intraocular pressure because they will have less risk to do that. So if you had a patient with glaucoma, that might be a better option for them. Even though you may have some risk, it'll be somewhat reduced. Triamcinolone is actually the intravitreal variety you can have there for injection. If you have dry eyes, basically we can use a lot of tear replacements, and so a lot of these things that can cause dry eyes can certainly be, irritants, environmental causes. You can have some even medical conditions that will do this, things like Stevens-Johnson syndrome and things like that. But basically what we're going to be doing is replacing the tears. If you have some sort of disease process that's causing the dry eye, fix that first. And then you can do other things like physical interventions, things like punctal plugs, or you can actually occlude the lacrimal drainage itself. Usually the tear substitutes we're going to use will either be hypo or isotonic solutions, so basically trying to mimic the tear solution itself, that will contain things like electrolytes, surfactants, and thickeners, things to make it stick around a little bit longer in the eye. And basically just replace what the tears would have been acting as anyway. So if you see things like carboxymethylcellulose, balanced salt solution, things like that, those are all going to be kind of tear replacements that can be utilized for dry eyes. One other drug that you can use for dry eyes, and this is more for refractory cases, is cyclosporin. This is actually an immunosuppressant where you might see it being used for, say, patients who have had organ transplants. This might be one of those drugs you see being used there, but this can also be used within the eyes. And so by inhibiting production and release of interleukin-2, you actually see less T-cell activation. So this might be better for a patient who, say, had an autoimmune condition, to something like lupus or something like that was causing dry eye. This can actually end up decreasing a lot of that inflammation. So you end up seeing increased tear production, end up seeing better vision and comfort for the patient. Really the only big thing you see with this drug is that it's very, very irritating to the eye, so it can cause some burning and a foreign body sensation, but it might be better for your patient than their chronic dry eye, depending on the case. So just another option there. Okay, almost through this section. Almost there, guys. Just want to make sure I get through all this before the test, right? So the next thing we'll talk about is our glaucoma and ocular hypertension. So we know glaucoma is going to be described as having basically elevated intraocular pressure, right? The problem with this is that you can have optic neuropathies, you can end up having permanent vision loss due to this, and so we want to prevent that if we can. So this is where a lot of our medications are going to come in. There's two varieties. You're going to have open versus closed angle. Open angle is mainly the thing we're going to be talking about as far as medications go. Closed angle is going to be more of kind of a surgical issue that can occur. And so the two things we're going to be focusing on with our medications is, one, we want to decrease the amount of aqueous humor that's being produced in the eye, and we also want to increase the outflow through the trabecular meshwork. Okay, so either increase outflow or decrease humor production, right? And that's not funny. You don't have to laugh. So normal ocular pressure, say anywhere between 10 millimeters of mercury to 21. And anything higher, this would be considered to be ocular hypertension, as long as you're not having any absence of visual field loss or nerve damage. Again, we said the open angle glaucoma is typically going to be either due to a blockage of the meshwork, preventing humor outflow, or it's going to be due to this increased production. Angle closure glaucoma, or that closed angle glaucoma, is typically due to an actual blockage of the drainage canal. And I'll show you a picture of that in just a second. Usually they're going to be like kind of an acute pain. The open angle glaucoma is kind of a more chronic condition, usually not a lot of symptoms associated with it. So you can see here the open angle, just the flow is not really being quite so physically impeded as you would see with the angle closure glaucoma. So this is why definitely more of a kind of a surgical issue versus more something we can manage with medications. Okay, so again, the goal of therapy, we want to prevent progressive optic nerve damage and hopefully have minimal systemic side effects from topical therapy. So the drugs we'll look at, again, we said there's two different mechanisms we're going to be looking at. You'll see how they kind of fall into different categories. So the ones that are going to increase aqueous outflow is going to include our prostaglandins, which typically you'll see being used as your first-line agents. You'll have alpha-adrenergic agonists and your cholinergic agonists will all help to increase outflow. And then you'll have those agents with decreased production, including your alpha-adrenergic agonists, so that you see those kind of do both. You'll have your beta blockers, which some people actually recommend beta blockers and prostaglandins either as first line, so that probably could be another acceptable first line, depending on who your teacher is. And then you also have your carbonic and anhydrase inhibitors. So we'll go more into details in a second.
For increasing outflow and decreasing.
Yeah, absolutely. We'll talk more about that just a little bit. So the first thing we'll talk about are prostaglandins, and so these are basically analogs of PGF2-alpha, and what they're going to be doing is that when they get into the eye, they're going to bind to the prostaglandin receptors and then decrease the intraocular pressure by increasing the actual outflow through that trabecular meshwork. How that actually works in the details, we probably don't really know all the details there, but we just know it works, right? So that's an important thing. The different agents you can see here include things like latanoprost, travoprost, bimatoprost. Notice that these are the ones I said are prodrugs that once they get, don't have any therapeutic efficacy themselves, once they get metabolized, they'll look more like the prostaglandin and can interact with those receptors. Yes?
I've seen the taste before as like a drug for eyelash.
Mm-hmm.
Like, yeah.
Yeah, we'll talk about that in just a second. I had a whole slide on that.
So, quick question. With
Yep.
the prostaglandins, you said prodrugs,
Mm-hmm.
but prodrugs have to be metabolized. And earlier we talked about how it bypasses first pass effect. So
Mhm.
would these be tablet form instead of drop form?
Nope, these are drops, but they get metabolized directly within the eye.
Okay.
Yeah, so metabolism can happen lots of different places. Just the majority of it happens in the liver, but this can happen within the eye itself. Yeah, good point. Side effects, you can see some hyperemia, some irritation, but the big thing here to focus on is that you can have changes in eyelash length and iris color, right? Not a lot of systemic side effects, which is why it's beneficial for a lot of patients. So look at this. You see a patient, you can imagine which eye was treated with a prostaglandin, which one was not. See that browning of the eye, right? And then if you look at this picture for the Latisse, you can see the increase in the eyelash length. So this is one of those drugs where it was kind of marketed for one purpose, and someone was like, oh, this is actually kind of a nice benefit. It's a nice side effect. Let's go ahead and market it for this too. Another popular one is minoxidil or Rogaine. Rogaine was originally an antihypertensive until they saw it actually cause increased hair growth. Now it's just used as a hair growth agent. So anyway, if your patient already has brown eyes, maybe it's not a big deal that they can utilize these, right? But if you have like just piercing blue eyes, maybe that's more important to them, right? So maybe that's a good reason why you might want to use a beta blocker instead. Okay. So again, look at your patient. Take into account these patient preferences. Let them know the side effects. Say, hey, you might have longer eyelashes, but your eyes are going to turn brown. It may not really be super good for them. Maybe some people just don't care. These might be good drugs for them.
So is that eye lengthener, but it changes the color of your eyelash?
Yeah, it's not 100% that's going to happen for everybody, and it's also probably not all that reversible.
Hasn't been shown to like cause massive amounts of cancer?
It's not that I'm aware of. But if you know something I don't, feel free to.
I thought I had heard that, but
Yeah, not that I'm aware of. Now, I mean, prostaglandins, your body produces those all the time, so.
no, I'm talking about Latisse.
Right, but Latisse is it's a prostaglandin analog, and I'm not aware of anything. But if you see something, let me know, and I can share it with the class. So, the next on the list is your beta blocking agent. So again, these might be considered first line, kind of interchangeable with the prostaglandins, depending on your patient. We'll talk about what that is. So these guys, as you might imagine, they're blocking beta receptors, so they're beta receptor antagonists. And so what this is actually going to do is decrease the catecholamine activation. So it decreases the second messenger cyclic AMP and produces less aqueous humor, right? So some available agents, you notice that some are considered to be beta-1 selective and some are non-selective. So what I mean by that is that beta-1 selective agents are going to only work on beta-1 receptors versus non-selective agents can work on beta-1 and beta-2 receptors. And that's going to be really important for side effects and contraindications in just a second. Now, the non-selective agents are probably going to be more efficacious on the whole, but they are going to lead to more side effects because basically there's more beta-2 receptors in the eye than beta-1, but you will see there's still some activity even if you use a beta-selective agent. So Betaxol, no, that's a beta-1 selective agent. Now, these agents are notable because you do have the possibility for having systemic absorption. So you can end up having systemic side effects. And beta blockers, if they affect the beta receptors in the heart, can lead to things like bradycardia, heart block, worsening heart failure if they already have kind of a poor cardiac output. And then the beta-2 receptors are primarily in the lungs. If you're blocking that effect and they have really bad reactive airway disease, that could potentially worsen the bronchoconstriction, maybe even make some of your medications for asthma work less effectively. So again, beta-1 receptors primarily in the heart, responsible for contractility and heart rate. So if you're using a beta-1 selective agent, primarily it's going to be working more in the heart when it gets absorbed systemically. Beta-2, if you use a non-selective agent, can affect both of these receptors. Okay. Keep in mind, beta selectivity or selectivity of any drug is only relative to its dose. So as you increase dose, you start to lose selectivity as well. So it could be a possibility that even if you use a beta-1 selective agent, you can still see some issues in the lungs. It's just much less likely, especially at therapeutic doses. So say if you had a patient who had glaucoma, you wanted to treat them with something. Say they had brown eyes and they had really bad reactive airway disease, asthma, and COPD. Okay. beta blockers using a non-selective agent might not be the best option for them. Maybe prostaglandin's good, right? Versus your blue-eyed patient who has no asthma, maybe a beta blocker is going to be a better option for them, right? So it's important on test questions to be able to kind of differentiate that and figure out which drug is best for your particular patient you're being asked about, right? Similar to what we saw in the quiz today. Okay. We can also have some alpha-adrenergic agonists. So these are going to be working kind of similarly to what we saw with some of the agents, kind of like the vasoconstrictors we saw, the imidazoline derivatives. These are going to be, has anyone heard of the antihypertensive clonidine? These are derivatives of that drug, if you've ever heard of it. But we'll talk more about that in antihypertensives. But these are going to be alpha-2 agonists. And so what they're going to do is actually work in kind of two different sites. Presynaptically, they're going to be working to decrease catecholamine release. So just like we talked about with the imidazoline, you know, if a kid swallowed some of that stuff, like just like you see in the brain, decreases CNS outflow. So that's going to help to decrease aqueous production and increases the outflow. And then postsynaptically, by binding the alpha-2 receptors, you can end up seeing decreased aqueous production. So these alpha agonists actually work through two different mechanisms, and so they're going to be doing decreased outflow or increased outflow and decreased production, right? So the two agents here we see are going to be aproclonidine and also bromonidine. Aproclonidine is nice because it's highly ionized at physiologic pH, which actually limits the amount of it that gets into the CNS. So you see less systemic side effects from it, versus bromonidine is more lipophilic, has a bigger chance to cross the blood-brain barrier and cause more systemic effects. So when you do have rapid removal of it, you can see that hyperemia, very similar to what we saw with the other vasoconstrictors, and you can see some allergic conjunctivitis with this, even though it's a little less common than bromonidine. These are going to be contraindicated in kids less than 2 years of age because of that effects we saw in the brain, causing decreased catecholamine outflow, so you worry about CNS depression and apnea, right? But fortunately, these usually for adults have pretty well developed blood-brain barriers. You're going to see less systemic side effects because of that. We also have our carbonic anhydrase inhibitors, and so these are going to work specifically by inhibiting the enzyme carbonic anhydrase. It makes sense. And so what they're going to be doing is by blocking that enzyme in the ciliary body, you're going to end up decreasing production of bicarbonate ions. And so by doing that, you actually decrease fluid transport, and so less aqueous humor being formed. You're going to have lower intraocular pressure. Two drugs that go in this category include dorzolamide and brinzolamide. Again, these are, you're going to see more systemic or more side effects from these drugs, which is why they're kind of lower down on the treatment algorithm because they're less well tolerated. So you see things like bitter taste and more stinging and burning when applying it. So this picture is probably the best one I can find as far as the mechanism of action. It's a little confusing, but essentially what you're seeing is that the flow of water is kind of happening from left to right, right? And wherever salt goes and wherever these solutes go, water is going to follow it. So this is kind of the direction of aqueous humor production. So by limiting the amount of bicarbonate ions that are formed within these cells, you're going to have less water flowing across eventually. And so this is why it's decreasing the intraocular pressure, because you're having less aqueous humor actually being formed. Okay. So just realize that inhibiting that enzyme is preventing the CO2 and the H2O from actually coming together and forming that bicarbonate. Yes?
So you're actually, are you keeping more sodium chloride in the anterior chamber? Which keeps more fluid there? So
No, not necessarily. It's more like it's kind of like on the systemic side where it can be more systemically absorbed and in the central circulation. Sort of, yeah. Okay. Again, further down on the treatment algorithm is going to be our cholinergic agonists. So these are going to work specifically by activating muscarinic receptors. So muscarinic receptors are going to be causing pretty significant side effects here. But the ones you'll see include acetylcholine, carbachol, and pilocarpine. Now, because of their frequent administration, because the side effects are pretty poorly tolerated, so they don't get used very frequently, and compliance is pretty bad. So you end up seeing these fixed closed pupils. So whenever you see that, you're either thinking like an opioid, like a hydrocodone or morphine, but you're also thinking cholinergic agonists. So that's where you see those really fixed myopic pupils. And again, younger patients are typically going to be more intolerant of this because of the visual blurring. If they can't see where they're going, they're probably not going to want to be all that compliant with therapy. Although, if you have a really older patient who is maybe already pretty poor vision, this might be an okay option for them because they couldn't have seen that well anyway, right? Just depends on your patient. So there's certainly lots of combination products that are available. So you can do things like combining bromonidine plus timolol, right? So you have comb again there. You have brinzolamide plus bromonidine. So you can have the ability to combine different drugs via different mechanisms in order to get more synergistic effects here. Okay. So fewer drops to administer, you're probably going to have better compliance. Okay. So again, who to treat If they don't have any risk factors, you can probably just monitor their intraocular pressure until you start to see some glaucomatous changes occur. But those with risk factors, say family history of glaucoma, things like that, you do want to go ahead and start treating. Typically, you're going to use either prostaglandin analog or a beta blocker, depending on your patient. We talked about some of those considerations. One thing I forgot to mention with prostaglandins, you really want to make sure you only use them once a day. Right? That's kind of one of the benefits, is you don't have to apply them very often, but if you use them more than once a day, you can actually end up seeing kind of a paradoxical increase in intraocular pressure. So really only use these guys once a day. Typically what you can actually do is start therapy in one eye just to see how they tolerate it. If they have really bad side effects, they always have the other eye they can see out of. So you can use that to actually determine tolerability and efficacy. You can do kind of a pre-post at the same time because you have one eye that's untreated versus one that is. And generally the goal is to get an intraocular pressure decrease of around 20 to 30%. Any questions on glaucoma? All right, we're in the home stretch. Thank you for hanging in there with me. So a couple other miscellaneous agents. These are going to be useful for diagnostic tests, but you have ocular anesthetics. Essentially what these drugs are doing is similar to what we saw with like your permethrins when we talked about working against insects. These actually work for human cells. They work on the neurons to prevent sodium channel influx. And so by preventing the nerve from conducting those action potentials, you prevent the sensory sensation from being transmitted to the brain. So even though the eye is being manipulated, the patient won't feel it, right? So tetracaine, proparacaine are the two big ones you'll see used ophthalmically. You can utilize it for things like foreign body removal, if you're doing superficial corneal surgery, tonometry, anything like that where you need to manipulate the eye, this is going to be good for that. I'm sorry? Tonometry is where you're actually testing the pressure in the eye. So this is where you kind of blow a big puff of air in their eye and see what the pressure is. Keep in mind that because the eye is numb, they're not going to have really a blink reflex. So the patient, this is not something you want to like prescribe for patients on an outpatient basis, just to use whenever they're having eye irritation. Because again, if they don't have the eye reflex or the blink reflex, they can end up having further damage being done to the eye, dryness and have abrasions done to it. But let them know for 10 to 20 minutes. You're not really going to feel the need to blink, but just try to remember to do every once in a while. We can also use some cyclo-pelagic agents, which basically impair the eye from constricting. That way you can get a better look for things like fundoscopic exams. And so you can use antimuscarinics for this. So instead of having something like pilocarpine, which activates muscarinic receptors, you're actually blocking the receptors here to cause the pupils to actually dilate, right? Again, this can lead to blurry vision and things like that, photosensitivity, just because they're having kind of all this light coming in. So you typically end up seeing the little glasses afterwards. The agents we can do with this include things like atropine, cyclopentolate, and also tropicamide. Probably the more common ones I see is the cyclopentolate and tropicamide. So like me working like in the PZD, this is a common frequent combination where kid comes in, they have they got something in their eye. You'll see them have an anesthetic being prescribed plus one of these cyclopelagic agents. So that way they can actually get in and do their exams on the eye. Kid's not really feeling it, and you can kind of do that unfettered, right? Other agents which can also potentially lead to mydriasis would be some pathomimetic agents. So ones that are activating catecholamine or sympathetic receptors, things like alpha receptors within the eye. So you can use things like phenylephrine, which you actually may see used systemically, like in some over-the-counter cough and cold products. But this also works in the eye to help cause mydriasis. So this is another agent you might see used instead of one of the antimuscarinic agents. Again, in combination with usually some ocular anesthetics, you may see fluorescein being used. And fluorescein is basically just a dye that can be applied to the eye itself, and then you get a Woods lamp put on there, and you can actually look for things like corneal abrasions. So if you're working in ED, it's probably a frequent combination of medications you'll see being used for ocular exams. Another dye you might see used is trypan blue or vision blue. This actually is more used for things like if you're having vitrectomy, because it actually can accumulate there in the eye. It can help the ophthalmologist actually do the surgery. So that's another kind of interesting dye you can see used there. All right, and that's it for ophthalmology. Is there any questions I can answer for you guys? I know it's quick, but I'll have videos out online so you guys can review those for the test. Any questions?
How many questions are there?
It'd be 50 questions.
And it goes up to here.
It'll cover up to here. Yep.
How much details should we know about the mechanisms of action?
All the detail. You should be able to recall what the detail. So like just like this test, you should be able to look at a drug, know the classification that it has, know common side effects, know indications, know the mechanism of action. You know, like I said, with the antibiotics, I'm not going to get super into like which ribosome specifically acts, but if you know in general what the drug is doing, so say like prostaglandins, I know they're decreasing, they're increasing outflow of the aqueous humor. Like that's probably good enough. Any question?